So when we talk about hemodynamics, it's basically looking at fluids and fluid behavior. And we can characterize fluid behavior in terms of the rate of the fluid, the rate of the flow. We can talk about the velocity. There's a lot of things we can use to characterize fluids. In this case, though, we're looking at blood because the movement of blood, we're looking at the velocity of the blood in the different chambers and blood vessels. We can also measure the pressures that the blood produce in these chambers and blood vessels. Gradient is something that is very important in echo. It's a pressure difference. When we talk about the gradient across something, it's just a pressure difference. And if you're going to have flow in one direction, then you need a gradient. You need a pressure difference because the fluid is going to flow from the highest pressure to the lower pressure. And that's, that's the basic concept of pressure gradient. We can also use hemodynamic data to look at shunts, atrial septal defect, ventricular septal defect, and we can characterize the magnitude of the shunt as well. Stroke volume, if you remember when we talk about stroke volume, is the volume of blood that's pumped from the ventricle per beat. So we can use hemodynamic principles to calculate stroke volume. And then just going from basic definition, cardiac output is stroke volume times the heart rate. Remember, cardiac output is the volume of blood that's pumped from the ventricles per minute. So if you can calculate stroke volume and you multiply stroke volume times the heart rate, you get cardiac output. And then cardiac index is when you divide the cardiac output by the body surface area. When you index anything, you divide by body surface area. We can calculate valve areas, especially patients who present with stenotic heart valves. And hemodynamics allows us to calculate valve areas. And by doing that, you can determine is this a mild, moderate, or severe valvulopathy. Okay. Also, similarly with regurgitant lesions, mitral regurgitation, trichosphere regurgitation, we can quantify the amount of regurgitation by using hemodynamic principles. And then regurgitant orifice area is another method of quantifying regurgitant lesions. So let's go into it in a little bit more detail. So the first concept that we're going to look at is the Bernoulli equation. The Bernoulli equation allows us to calculate gradients. And if you have a closed circuit, okay, say you have a tube. When we say closed circuit, say you have a tube, and you have blood flowing from one point to the next point, or anywhere along the tube. The flow throughout the tube is going to be the same. As long as there's no leak in the tube, the flow throughout this tube is going to be the same. And the flow is going to be from the high pressure to the low pressure. And that pressure difference is what we call the gradient. One second. So the Bernoulli equation allows us to calculate gradients. And I say gradients is basically the pressure difference which allow flow from one direction to the next. All right, so let's look at it in a little bit more detail. So this is what we're talking about. So if you have a tube, even if you have an obstruction in the tube, the flow at, say, point 1 is going to be the same as the flow at point 2. The flow is going to be the same. The pressure, well, you have an obstruction at point 2. The pressure at point 1 and point 2 is going to be different. You're going to have a higher pressure at point 1, higher than point 2. So a quick rationale is, okay, so if the pressure at point 1 is greater than the pressure in point 2, you know, and we said the flow at point 1 is equal to the flow at point 2. The difference is the velocity. So at point 1, you're going to have a lower velocity. At point 2, you're going to have a higher velocity. And if you remember when you used to play with your garden hose and you narrowed the nozzle of the garden hose, the water went further. And it's the same principle. You know, if you narrow the hose, you're going to decrease the pressure, but you're going to increase the velocity. The flow is going to be the same though. So this equation allows us to calculate pressure gradient or pressure difference. So if this is the pressure difference, pressure gradient, P1 minus P2, it is equal to convective acceleration plus flow acceleration plus viscous friction. So this is the basic formula, okay? I don't want you to know all of that. I mean, you know, it's a very complex formula. And
thank God. Thank God.
If you had to memorize all of this, then I think most people would drop out of echo. So let's look at it though. So, and just looking at it, I mean, when you have flow from one point to another point because of pressure difference, a gradient, there is viscous friction. The viscosity of the fluid is going to affect the flow. Common sense. And then flow acceleration. So the flow acceleration, you know, if you did basic mathematics, the integral of the velocity with respect to time, that's the acceleration. So how the fluid is accelerating. And then the convective acceleration, which is half rho, which is rho is the density, times the velocity squared at point 2 minus the velocity squared at point 1. So this is the basic formula. However, for blood, okay, so for blood, let me just go back to the formula. For blood, the viscosity is negligible. Okay, flow acceleration is also negligible. So you can you know these you can drop these. So the flow acceleration and viscous friction, because the viscosity of blood is not it's not very viscous, so you can neglect viscous friction and flow acceleration. So what you're left with is pressure gradient is equal to half rho multiplied by the square of the velocity at point 2 minus the square of the velocity at point 1. The velocity, because you have a narrowing at point 2, the velocity is going to be greater than point 1. So we ignore flow acceleration and viscous friction. So we are left with this, just this as the gradient. So it's half of rho multiplied by the square of velocity at point 2 minus the square of velocity at point 1. But for blood, half rho is equal to 4. Rho is the density. Okay? So half rho for blood is 4. So when you simplify the equation, you get 4 times the velocity at point 2 squared minus velocity at point 1 squared. You can ignore, because the velocity at point 1 is usually, if you have a narrow or a short obstruction, you can ignore the velocity at point 1. So the formula can be condensed into pressure gradient, which is the pressure difference between point 1 and point 1 and point 2, the pressure difference, and we use this symbol as gradient, is equal to 4v squared. So we simplify the equation straight on to 4v squared. Pressure gradient is equal to 4v squared, and this is the modified Bernoulli equation, and that's all you have to remember. Okay, so the gradient, which is the pressure difference between 2 points, is equal to 4v squared, where v is the velocity. Let's look at tricuspid regurgitation, because we went through all of this to see how we can calculate gradients in the chambers. So let's look at tricuspid regurgitation. Okay, tricuspid regurgitation. The definition of tricuspid regurgitation is blood flowing from the RV across the tricuspid valve into the right atrium. Tricuspid regurgitation. As we just said, in order for blood or fluid to be flowing from one direction to the next, you need a pressure difference. So if blood is going to flow from the RV across the tricuspid valve into the right atrium, the pressure in the RV have to exceed that in the RA. So the gradient, which is the RV pressure minus the RA pressure, is equal to 4v squared, the velocity of the blood going backwards squared. So again, the gradient is equal to because remember, tricuspid regurgitation occurs in systole. So it's going to equal to the RV systolic pressure minus the right atrial pressure, because blood is flowing from the RV across the tricuspid valve into the right atrium. That is the gradient. And as we said, the gradient is equal to 4v squared, the velocity, the TR velocity squared. Now, if we one of the things that we calculate when we do echo is right ventricular systolic pressure, or the RV systolic pressure. So one of the things that we calculate is the RV systolic pressure. And the RV systolic pressure is the same thing as the pulmonary artery systolic pressure, unless, if you don't have an obstruction at the right ventricular flow tract, the RV systolic pressure is the same thing as the pulmonary artery systolic pressure. And when we start, looking at the right side of the heart, we'll go into this a little bit more. But one of a very important calculation that we do in echo is the RV systolic pressure, right ventricular systolic pressure. Because if the RV systolic pressure is very high, patient can develop right ventricular failure. And not only right ventricular failure, but it is a sign of a diseased heart. So, and then when we talk about pulmonary hypertension, elevated right ventricular systolic pressure is a measure of pulmonary hypertension unless there's an obstruction at the right ventricular flow tract. If there is no obstruction, then the pressure, the pulmonary artery systolic pressure is going to be similar or the same as the right ventricular systolic pressure. We'll get to that. But so this is how we calculate it. So this is short axis at the level of the aorta. Short axis. Again, this is your transducer right there. Short axis at the level of the aorta. This is the aorta. This is the RV, right ventricle. Okay. Your tricuspid valve is right there, and the right atrium is right there. The cursor is across the tricuspid valve, and you put your CW on, continuous wave Doppler. Because blood is flowing from the RV across the tricuspid valve into the right atrium. It's moving away from the transducer, so it's going to be below the baseline. It's going to be below the baseline. And TR velocity, sorry, this is a tricuspid regurgitation envelope. Okay, it's a systolic flow. And again, systole is from the onset of the QRS to the end of the T wave. It's a systolic flow. Again, when we look at these graphical representation of flow, on the horizontal axis is time, and on the vertical axis, we have velocity. So this is the velocity we're talking about, because you're having a flow going from the RV across the tricuspid valve into the right atrium. The pressure in the RV have to exceed the pressure in the RA, causing the blood to flow in this direction. And the gradient, which is the pressure difference between the RV and the RA, is equal to 4V squared, and this is the velocity we're talking about. So this is the velocity. So you can calculate the right ventricular systolic pressure. Again, if the RV systolic pressure is crucial in cardiology and in echo, so you have to know how to measure it and how to measure it accurately. The RV systolic pressure is the same as the pulmonary artery systolic pressure. Remember, in the pulmonary artery, you have a systolic and a diastolic pressure. The systolic pressure in the pulmonary artery is the same thing as the RV systolic pressure, unless there's an obstruction at the right ventricular flow tract. So this is also relatively simple. So we get the pulmonary artery systolic pressure. So this velocity is 2.89. You square the velocity and you multiply it by 4. Okay, and you get, so this is the gradient. Remember, so let's go back. The gradient is equal to the RV systolic pressure minus the RA pressure. If we want to calculate the RV systolic pressure, then we have to transport the RA pressure over here, and we have to rearrange the equation. So we're going to have to add the RA pressure to the gradient to get the RV systolic pressure. So, a simple math. So the RV systolic pressure is equal to the gradient plus the RA pressure. All right, so we can calculate the PA systolic pressure. What about the PA diastolic pressure? When you go to the ICU and they ask you about the pulmonary pressures, you're not only reporting the pulmonary artery systolic pressure, but you have to report on the pulmonary artery diastolic pressure. You have to report on the pulmonary artery diastolic pressure. Now, if we're gonna do some thinking, because hemodynamic is just really thinking, a little deeper thinking. So when you have pulmonary insufficiency or pulmonary regurgitation, when you have pulmonary regurgitation, blood is going to flow from the pulmonary trunk across the pulmonary valve into the right ventricular outflow tract, or into the right ventricle. That is pulmonary regurgitation. PR, pulmonic regurgitation. Blood is going to flow indiastole from the pulmonary trunk across the pulmonic valve into the right ventricular flow tract. It's a diastolic phenomenon. So again, blood is only going to flow if there is a pressure difference. So what you're saying, for you to get pulmonic insufficiency, the pressure in diastole in the pulmonary trunk have to be greater than the pressure in the right ventricle in diastole. So the gradient, which is the pulmonary artery end diastolic pressure, minus the RV end diastolic pressure, this is what's going to cause pulmonic regurgitation, the pressure difference. And blood is going to flow from the pulmonary trunk across the pulmonary valve into the right ventricle. So this is the gradient. And that gradient is equal to 4V squared. We already know that. Okay? If you want to get the pulmonary artery end diastolic pressure, then you just rearrange the equation, and the pulmonary artery end diastolic pressure is equal to the gradient plus the right ventricular end diastolic pressure. But the right ventricular end diastolic pressure is the same thing as the right atrial pressure. So this is how you do it. Again, pressure gradient is equal to 4V squared. I mean, that concept we already developed. So short axis at the level of the aorta, when you have pulmonic regurgitation or pulmonary regurgitation or pulmonic insufficiency, the same thing. Blood is going to flow from the pulmonary trunk across the pulmonary valve into the right ventricle. And you get an envelope looking like this. It's a truncated envelope, okay? You're going to have an early velocity and a late velocity. It's a diastolic flow, so it's going to flow. You're going to get the envelope from the end of systole to from the end of the T wave to the beginning of the QRS, because it's a diastolic flow. End of the T wave, beginning of the QRS. It's a diastolic flow. So and you're going to have an early velocity and a late velocity, okay? So it's what we want to calculate is the pulmonary diastolic pressure, the pulmonary artery end diastolic pressure. So we have to use the late velocity, not the early velocity, the late velocity. So you're going to have two velocities. See, the early velocity is 2.58, there, and the early velocity is 1.26. So that's what you're going to do. You're going to square this velocity. You're going to square it and multiply it by 4, and that's the gradient. To get the pulmonary artery end diastolic pressure, you're going to add the right atrial pressure to that, to the gradient. Now, you said I'm talking about right atrial pressure, and I'm not showing you how to calculate right atrial pressure, but we'll look into that. Okay. Okay. So what about calculating the left atrial pressure? Again, these are not just measurements we pull out from the hair. These are measurements that have clinical implication, because when someone goes into heart failure, the left ventricular end diastolic pressure, which the left atrial pressure is a measure of goes up. So one of the first thing when someone goes into heart failure, whether it's diastolic heart failure or systolic heart failure, the left atrial pressure will go up. So measuring the left atrial pressure is very, very crucial in cardiology. But we can use echo to measure the left atrial pressure. Again, using gradients. If we look at mitral regurgitation, look at mitral regurgitation. Mitral regurgitation is blood flowing from the LV across the mitral valve into the left atrium, and that's a systolic phenomenon. So there have to be a pressure difference for the blood to be flowing from the LV across the mitral valve into the left atrium. That pressure difference is called the gradient. So the gradient will be the LV systolic pressure, because this is a phenomenon that occurs in systole. The LV systolic pressure minus the left atrial pressure, which is the gradient, is equal to 4V squared. We said gradient is equal to 4V squared. So the gradient is equal to the left ventricular systolic pressure minus left atrial pressure. If we rearrange the equation, then we see that the left atrial pressure, which is crucial to measure because when patient goes into heart failure, this goes up. So the left atrial pressure is equal to the left ventricular systolic pressure minus the gradient. Just a little extra thinking, the left ventricular systolic pressure is the same thing as the systolic blood pressure. The left ventricular systolic pressure is the same thing as the systolic blood pressure, as long as there is no obstruction across the aortic valve or the left ventricular flow tract. So we measure the blood pressure, we get that. So the only thing we need to measure to know is the gradient in order to calculate left atrial pressure. But we know the gradient is equal to 4V squared. So basically what you're going to do when you get, you can use a 4-chamber view, you can use the 2 or the 3-chamber view. And if there's mitral regurgitation, again, the cursor is across the mitral valve, the sample volume is right in the mitral valve, and this patient have mitral regurgitation. The transducer is right there. With mitral regurgitation, blood is going to flow from the LV across the mitral valve into the left atrium. So it's going to move away from the transducer. Hence, it's below the baseline. So you see the envelope below the baseline. It's a CW measure because the velocity is usually about 5 meters per second. And it's a systolic flow from the onset of the QRS to the T wave. Onset of QRS to the T wave. So, and it has a velocity. The peak velocity is right there. In this case, it's 5.54. So this is the velocity we're talking about, the MR velocity. So the pressure gradient, which is the difference between the LV systolic pressure and the left atrial pressure, which is equal to 4V squared. If we substitute V in the formula, then we get 122.9 millimeters mercury. Rearrange the equation, then left atrial pressure is equal to the LV systolic pressure minus 122.9. As we said before, the LV systolic pressure is the same thing as the blood pressure, the systolic blood pressure, as long as there is no obstruction across the LVOT. And you can calculate that left atrial pressure. Okay. Now we can. So when we look at the LV, the left ventricle is going to have a systolic pressure, which is the same thing as the systolic blood pressure. So it's going to have a systolic pressure and a diastolic pressure, just like the pulmonary artery. going to have a systolic pressure and a diastolic pressure. How can we calculate the left ventricular end diastolic pressure? Just extra thinking again. If we have aortic insufficiency, aortic regurgitation. Aortic regurgitation is a diastolic phenomenon where you have blood flowing from the aorta. It's going to go in the opposite direction now. So blood is going to flow from the aorta across the aortic valve into the LV in diastole. That's aortic insufficiency. The only reason that's going to occur, the pressure in the aorta after exceeds the pressure in the LV in diastole for blood to flow in that direction. So we're talking about the aortic diastolic pressure minus the LV end diastolic pressure, that's the gradient, and all gradients from the modified Bernoulli equation is equal to 4V squared. So if we want to calculate the left ventricular end diastolic pressure and we rearrange the equation, then we get the left ventricular end diastolic pressure is equal to the aortic diastolic pressure minus the gradient. And again, the gradient is 4V squared. The aortic diastolic pressure is the same thing as the diastolic blood pressure. The aortic diastolic pressure is the same thing as the diastolic blood pressure. So you just substitute that in there. So what velocity are we talking about? When you have aortic insufficiency, so again, two-dimensional echo here, your transducer is right there. And this is a three-chamber view. The cursor is across the aortic valve. The sample volume is right at the aortic valve. And aortic insufficiency looks like this. So it's a truncated envelope. It's a diastolic envelope from the end of the T wave to the QRS. End of the T wave, QRS. It has a early velocity, a late velocity, or an end diastolic velocity. Okay? You want to use the end diastolic velocity. So this is the velocity you're going to use. Not the early velocity, but the end diastolic velocity. So you're going to square it, multiply it by 4, and you get the gradient. So the left ventricular end diastolic pressure is equal to the diastolic blood pressure, which is the same thing as the diastolic aortic pressure, minus 4V squared. This is the velocity you're going to use, B. And you'll get the left ventricular end diastolic pressure. All right, so we're going to stop here, and you're going to have to go over it a million times because more than likely you weren't familiar with this concept. It's a relatively straightforward concept, but the fact that you were not exposed to it before, you're going to have to go over it until it becomes a part of you.